Good morning. I'm Dr. Sylvia Ziegenbein. I'm an OBGYN for the department at the Med Center. I've been asked to talk about the most fun subject of all, sexual dysfunction. It is not the first thing in a lady's mind when she is diagnosed with cancer. It goes way to the back of your mind. It's the last thing you want to even think about. So when I see patients for this issue, it's usually they're through the most rigorous part of their treatment. They're usually survivors. This topic's full of lots of deep emotional, psychological things that go to our core. So it gets a little emotional even for me talking about this topic because I feel so badly for many women. Sorry. Okay. My objectives today are just to discuss some of the most common complaints, mostly physical. I'm not a psychologist, but there is a lot of psych issues in this topic. But we'll talk about the most common complaints regarding sexual function in cancer survivor patients. We'll discuss some strategies of treatment for those problems. We'll talk about communication. I was asked to talk about communication skills and bringing up these topics. It's difficult, but it should just be part of the general H&P that we talk about with patients. It should be a point in our list of things that we're asking patients about. We're sexual beings, but to be a sexual being, you have to have your health. All right, sorry. This comes up on the internet. It's just kind of hilarious when you look on the internet about sexual function, but it's also very important. And this is kind of the problem with bringing up sexual dysfunction is we don't want to be stigmatized. We just want understanding and we want help. When you go see a physical therapist for sexual dysfunction, they have charts of usually a little less descriptive as these, but sexual positions that you can do to overcome some barriers. And usually it's pain, hip pain, or pelvic pain, something like that, and different positions you can try. I don't have any financial disclosures. I wish I did, but I don't. Okay, so sex has these stages: desire, arousal, plateau, orgasm, resolution. All right, this is all clean and sterile, organized. It was Masters and Johnson who came up with all these stages. It's important for all of us to just know some of the different things with sex, but sex is not this clean or sterile. Sex is messy. Okay, so many of you have heard about this book, the Kama Sutra, and you think it's about sexual positions, but really it's a book of wellness, how to live a fulfilling, healthy life. And so, yes, sex, intimacy, love is part of our healthy well-being. This is an image from the internet. It's ancient text in Sanskrit. I mean, that's what the internet tells me it is. It's the Kama Sutra, but I can't read it, of course. Okay, so when I say sex is messy, it's deep, psychological. There are lots of, everybody's different. Everybody thinks of different words when we think about sex. But when I am dealing with sexual dysfunction, a lot of deep emotions, things that how we are brought up, our religious background, our parents, school, how we got teased, so a lot of different issues with sex. So these are some of the words that I came up with, and you can't psychoanalyze me. But oral, anal, vaginal, gender, good, bad, love, hate, intimacy, pregnancy, children, condoms, luscious, odor, grooming, foreplay, porn, vibrators, sex toys, pain, pleasure, ugly, beautiful, embarrassed, light bulb, gerbil. Sorry, I'm an OBGYN and we deal with these stories, not all the time, but occasionally. Rape, asexual, religion, religious, parents, hidden, mysterious, secret, relationships, deep personal psyche, animalistic, all the time, never, who are we? So sexual dysfunction in cancer patients, cancer diagnosis is abrupt, it's not planned for. It happens when your relationship is great, when it's terrible, it adds so much, which I can't pretend to know. But it happens in younger patients and older patients. I'm not talking about pediatrics today, but I think my youngest patient, she's actually a stem cell transplant patient. And when we go through stem cell transplants, we get so much chemotherapy, it often damages our ovaries to where they're not making hormones anymore, and it puts ladies into menopause. So if you're 17 and you get a stem cell transplant for sickle cell disease and it puts you into menopause, that's a huge deal. But no, I haven't treated anybody younger than that. Menopausal, premenopausal. You're married or single, multiple partners, same-sex partners, open relationships. It affects the spouse, life partners a lot. Of course, patient herself first, and then everybody in her tight group. All walks of life. Cancer thoughts are pervasive. They cause stress, anxiety, depression, insomnia, grief, substance abuse, withdrawal, guilt. We would love it if every patient who had a cancer diagnosis changed their life, and maybe not change is the right word, but maybe we were drinking too much or smoking too much and we got cancer, and we would love everybody to have the most well-lived life after that, living healthy, eating right, exercising, all those things we wish we could do every day. We want cancer patients to have the best life ever, but it doesn't happen all the time, right? It's a difficult situation. All right, so with this cancer diagnosis, sex often stops. Sex, we need health to be sexually active. We need to feel good about ourselves. We need energy. We need to be able to spread our legs, right? Or not necessarily, but different positions. We have to not have terrible arthritis. We can't have a broken leg. We can't feel badly. We can't have pain with it generally, or we're not going to want it. That's just normal. But we have other things to worry about and think about. And so sex goes way back on the back burner. We're anxious, we're worried, we hurt, we don't feel good about ourselves. One of our breasts might be missing, and no way do I want to get naked. We don't feel whole, we don't feel like a woman, we don't feel beautiful. Self-esteem for women, self-esteem and feeling good. So I usually tell ladies that sex is 95% up here for women. For men, it's 95% down there. So we're very mental when it comes to intercourse and sex and intimacy. You don't want to have sex when it feels like razor blades, when you have vaginal sex and it hurts. It's just a normal response to say, heck no. And then a lot of guilt comes because maybe our husband or life partner wants to be intimate. And there are other ways to be intimate. You don't have to have vaginal sex, but other ways to be intimate, but you can't, you don't have that feeling right now. So lots of things with sex, not just physical. But if it's not bothering the patient, it's not really bothering me. You don't have to have libido if it's not bothering anybody. What if your partner has no libido too, and then you get libido and there's a mismatch? So lots of things you have to discuss, but we need to be open and honest, safe, caring. All right, so now the most common problems we see, vaginal dryness is a big one. Pain with deep thrusting is not as big. So a lot of these patients with breast cancer are on treatment that cause vaginal dryness tremendously, like aromatase inhibitors. But menopause all by itself can do the same thing. When ladies are on tamoxifen, it's usually not as bad. But then again, you get patients who are thrust into menopause because their ovaries die off because of chemotherapy. So, okay, vaginal dryness. We usually start with lubricants. Lubricants are gels that you use during sex. Silicone's the best. Moisturizers are moisturizers that you put in the vagina that keep the tissue as healthy as possible, non-hormonal. And there are hyaluronic acid products that seem to be the best, and they're newer on the market. Halogyne is one of them. Replens is one of them, over the counter. We used to talk about coconut oil or vitamin E oil, any natural oil, but sometimes ladies, I've read, occasionally ladies will get different reactions to them, maybe even yeast infections. But I still think coconut oil is a nice option because it's cheap and it's kind of solid at room temperature, so you can get a small chunk and put it in the vagina. Now, vaginal estrogen, if you have breast cancer and it's estrogen receptor positive, vaginal estrogen is still doable, and it still is the best product for the vagina. But breast cancer, it's second line. You have to fail other things first. So breast cancer patients, this will be an option. We want to talk to the patient about risks. As far as we know, low dose vaginal estrogen does not increase your risk of breast cancer. But we just don't feel like we have enough data. It's ultra low dose. It works great. It helps your bladder. So usually in menopause, we get vaginal dryness. We can get an irritated bladder. We can get vulvar itching or itching on the outside, all just from lack of estrogen. So estrogen can help all of those. We should talk to the patient about some unknown risks. We usually communicate with the oncologist and that we've tried this, this, and this, and vaginal dryness is affecting the patient's life, and so I'm going to start ultra low dose vaginal estrogen. We have tablets, we have creams, we have a vaginal ring. Okay, other options. This DHEA, this vaginal suppository, it's called prosterone. That can help vaginal dryness. It's newer. We're not convinced, well, we don't think it's probably any better than estrogen. But this DHEA can convert to testosterone and estrone in your bloodstream. So it can increase DHEA and testosterone and estrone levels. We can see that in our blood. It's still not above postmenopausal levels, but we're not quite sure about this as far as breast cancer risk. There is some data that testosterone can increase one's risk of breast cancer. So we're very cautious with these products. Ospemifene is an oral tablet that helps the vaginal dryness. So in somebody who has terrible arthritis, maybe this is an option. But this is a SERM, kind of similar to tamoxifen. It turns on the estrogen receptors in the vagina without turning on the uterus or the breast. It's neutral on breast tissue, if not negative. But it can slightly increase your risk of blood clots potentially, or it might increase hot flashes. So SERMs, selective estrogen receptor modulators like tamoxifen, they turn on and off estrogen receptors in our body. It does turn on bone estrogen receptors, so it can be good for, it can be really good for osteoporosis. Okay, and then you've heard about laser treatments in the vagina. Some of the studies show that it's fantastic in remodeling that vaginal tissue, but when we started using it on more and more people, there were burns, there were problems. So right now we're not to recommend laser for the vagina. You know, you go to a med spa and they do laser on your face and it remodels the collagen, making it less wrinkly and more plump. So the thought was laser for the vagina could help. We're not quite there yet, maybe in the future. Pain with deep thrusting is usually another problem. So vaginal dryness feels like razor blades, initial penetration, it hurts. The deep thrusting is usually a different problem, like endometriosis. Endometritis is inflammation of the uterus. There might be a pelvic mass or something else going on. So I don't run into that very often. Although at the beginning, when somebody comes in with terrible vaginal dryness, they might say it hurts with deep thrusting, initial penetration. So fix the dryness first and then go from there. All right, decreased libido is a big one also. Now libido, like I said, 95% of our sexual being is up here in our head. So you have to feel good about yourself. You have to have energy. If you have pain with sex, you're not going to want to have sex. You know, no, don't touch me down there. It hurts. It's a protective mechanism. So, you know, and then with any relationship and intimacy, there might be a lot of resentment with your partner. There might be a lot of other issues. So you got to kind of go through some of that. Let's get somebody healthy and feeling well and fixing the pain with sex, and then things will improve. But other treatments on this right side, other things, date night, more rest, make sure you're getting some sleep. You know, if you're working 3 jobs, yeah, you might have to go pull back on work. Might want to get some erotic materials, movies, magazines, pictures, erotic toys. Weight loss is a big one. For me, if I lose 5 pounds, I'm a little more frisky. I just feel better. Treat vaginal dryness if you have vaginal dryness. Change or decrease meds. So I think on the next page, so some ladies will complain about can't orgasm. Medications, the most common that I see are medications for anxiety and depression, like Zoloft or Lexapro or Celexa. These medications for anxiety and depression can affect orgasm. It might be very difficult to orgasm, and if you're struggling to orgasm, it's not as fun to have sex. So we can decrease medications. That was just on the bottom of that previous slide. Change or decrease meds. So if we get to where we think a med's causing it, we can change that. All right. Now you'll notice I haven't mentioned hormone replacement therapy at all yet. And in a postmenopausal patient, hormone replacement with estrogen and progesterone is really 50-50 for a lady's libido. It really hasn't been shown to be great. So when you hear all these commercials about hormone replacement, it's kind of, it's unsavory. They just want your money. So be very careful. And so when we talk about hormone replacement therapy, generally we're talking about estrogen and progesterone. And we just do estrogen only if a lady has had a hysterectomy. So it's really 50-50. It doesn't affect libido as much as you think it would. Testosterone supraphysiologic dosages can increase libido, but it also increases endurance and strength, vitality. So you probably feel better. It's easier to lose weight on testosterone. You're probably gaining some muscle mass. But testosterone all by itself may increase your risk of breast cancer. So we don't give out hormones for libido very often. We have a long discussion. Okay, the ultra low dose vaginal estrogen helps pain with sex, helps dryness, helps the tissue be more supple. All right, so recap: most common causes of sexual dysfunction in cancer survivors: painful sex, so usually dry, raw. In my cancer survivors who have had stem cell transplants, you can get graft versus host disease in the vagina, and it can be terrible. It can be like you're sloughing off of a layer of your vaginal tissue, and raw, irritated. So we usually use steroids for that part and some vaginal estrogen, but that's graft versus host disease. In patients who have graft versus host disease, the oncologists who work on all the other graft versus host disease going on in the body, once they calm that down, the vagina usually gets healthier. Okay, so painful sex, usually lubricants, vaginal moisturizers, vaginal estrogen. Sex helps the tissue stay healthier, so use that as you may. Second thing, decrease libido, maximize one's health, lose weight, eat right, don't drink too much, stop smoking, don't do illicit drugs, treat the anxiety, depression, improve the arthritis, okay? And then can't orgasm, even with self-stimulation. So think about adjusting medications. For me, it's rarely organic, but diabetes, multiple sclerosis, other conditions that affect nerves and blood vessels can affect orgasm and sexual function. Generally, it's medication if you're pretty healthy otherwise. Okay, thank you very much. I love talking to you. Ask your questions, and I appreciate your time.